Think forward. Think Research Channel.
Let me get started at introducing a wonderful individual. Today, Dr. Jeff Ebersole. He's the Associate Dean for Research in the College of Dentistry. Jeff received his PhD from the University of Pittsburgh School of Dentistry and Microbiology and did his postdoctoral work at the Forsyth Dental Institute in Immunology. He is on a number of editorial boards, as well as has over 200 peer-reviewed journal articles, as well as the PI and co-I on a number of NIH grants. And as I said, his work exemplifies this multidimensional team that not only is he working with individuals within the College of Dentistry, but also the College of Medicine, a variety of different departments, as well as institutes outside the university. So it truly embraces the vision of the NIH. And with that said, I'm going to turn it over to Dr. Ebersole. The title of his talk is Oral Disease in Non-Human Primates, Translational Research Models of Oral Systematic Disease. Dr. Ebersole.
Thank you. Yeah, I can probably just do it here. Thank you, Jeannie. Appreciate it. First, I'd like to thank Dean Perman for supporting this really neat activity, and Jeannie and the clinical research activity in medicine for inviting me to speak to you today. When I was asked to do this a few months back, looking at the thread of presentations over the last number of months in this series, they focus very much on human subjects and potentially biological specimens in the laboratory, but from human subjects. And I thought what I might be able to bring to the table that would be a little bit different would be to focus on what I'm calling translational research, and that is the way that we're using the non-human primate as a model of human disease. The presentation today, I thought I'd break down into 3 or 4 small pieces. The first, to give you a little bit of background on periodontal disease so that we're all sort of on the same page and you understand why we're asking the questions that we're asking. The second was to give you a little bit of background in the non-human primate of this model of this disease so that you understand some of the parameters of it. And then finally, I have 3 different virtual snapshots of the way that we're using the non-human primate to look at oral diseases and chronic inflammation, as well as to try to better understand the biology of the link between good or poor oral health and systemic sequelae of that chronic infection. And I'll try to get through all of that. Now I got to try to get through all of that today. Depending upon the time, I can sort of cut the snapshots a little bit short. First of all, I thought I'd just show this kind of a picture so everybody really does understand the severity and chronicity of this disease that we're talking about that affects nearly 50% of the population of adults in the United States. It is a chronic infection with an accumulation of a multitude of bacteria. We'll talk a little bit about that during the lecture, that accumulate on the tooth surface, dramatically affect the inflammatory response in the gums that are involved in holding the teeth in, as well as the underlying bone structures. I'll show you a picture of that briefly. It can lead to severe suppuration, literally pus coming out from around the teeth, as well as bleeding as a measure of a severe inflammatory response. Left untreated, it can progress to exfoliation of the teeth. Unfortunately, Kentucky is the highest rate of edentulism in the country, and these are the kind of patients that end up like that, in which the majority of the bone holding their teeth in place has been lost because of a chronic infection and the chronic inflammatory response to that infection. Just a few snippets of information on periodontitis so that you understand again why we're asking some of the questions. It is an inflammatory disease as defined by this term. It is an infection. We believe that there are some specific bacteria that are associated with this infection, and they likely exist in what's termed pathogenic consortia in biofilms. So it's an organization of bacteria. It's not a single monoinfection that we're dealing with. We're dealing with bacteria that interact in a food web in that environment, so they feed off of each other, as well as likely contributing to a virulence web in which the responses to one organism will affect how that other organism survives within that milieu. Importantly, there are different complexes of these bacteria in health and disease. We'll talk a little bit about that. And almost as importantly is these really represent opportunistic commensal pathogens. They are organisms that we all acquire very early in life. They establish individually in our oral cavity, and you will carry them throughout your life. So it's a constant interplay and evolution of the organisms in the oral cavity, as well as the ability of the individual host to respond to those, which either has homeostasis, health, or can lead to a tissue destruction and a disease process. So it's quite different than the idea of acquiring a Streptococcus pneumoniae infection and developing pneumonia. The disease process is not caused directly by the organism. It really is collateral damage. We have this mass of bacteria living in the oral cavity. The host inflammatory and immunologic response tries to control and manage this infection, and in certain individuals, under certain circumstances, this results in the destructive aspects of the disease. So it is a chronic inflammatory disease with many features similar to medical chronic inflammatory diseases such as rheumatoid arthritis or Crohn's disease. The biofilms are the trigger, nevertheless. The bacteria trigger this chronic inflammation that can destroy soft tissues, which we'll call that is called the gingivone. We'll talk about that as well as the underlying hard tissue, which is the alveolar bone that supports the teeth. The working concept now is that this likely represents a dysregulation of the host response. That normally you must respond to these organisms. They're there. We have to interact with them as an individual host. But in some individuals, that homeostasis of the relationship between the bacteria and the host is dysregulated, which results in the tissue destruction that we call disease. And finally, a concept that has actually evolved over probably the past 15 years is if you went back longer than that in textbooks, you would see issues about, well, as you age, 90%, 100% of the population are going to develop periodontitis. That actually isn't true. Probably 100% of us will develop gingivitis, which is a reversible inflammation at some point in time during our lives. But there's a high-risk population, a subset of maybe 25% of the population, that really is at risk for the severe destructive type of disease. Whether they have different pathogens or a genetic predisposition to a response profile that would lead to disease is still continually under investigation. One of the things that sparked a lot of what I'm going to talk to you today about is a report from the Surgeon General in 2000 called Oral Health America, a report of the Surgeon General. And cut to the chase, his conclusions were that oral health is integral to general health. That seems like oh, I should have had a V8. Of course the two are related. But historically, dental research focused on the oral cavity, medical research focused on everything but the oral cavity, and we did not get those two things together very well. That has been improving dramatically over the past 10 years. Drilling down a little deeper, some of the conclusions that he came up with are fundamental to things that we're now doing in and focusing on in dental research. The first was that there are profound and consequential health disparities in the U.S. population. Again, vulnerable populations, at-risk populations. How do we identify and predict who they are? The mouth reflects general health and well-being, so we see a variety of parameters in the oral cavity that actually reflect altered systemic health. And the flip side of that is that oral diseases can contribute to systemic diseases, can help contribute to the sequela of various systemic diseases, one of which we're going to focus on today. This is sort of a cartoon to give you an idea of the kind of diseases that we have some data that's been developed over the 10 to 15 years, linking oral health on this side with systemic health on this side. And the data suggest fairly strongly that the severity of periodontitis is altered significantly in type 1 and type 2 diabetics. And this is likely a two-way street, so not only does the diabetes affect oral health, but the oral health affects the management of the diabetic patient. There's some linkage to atherosclerosis and cardiovascular events. And finally, the one that I'm going to focus on today is the incidence and outcomes of preterm birth and low birth weight infants. If you just look at this side of the equation, you say, how can they all be related? They're so different in their outcomes and potentially the underlying mechanisms. But fundamentally, there is a common biological plausibility linking this oral disease to these systemic sequelae. And that is, the oral disease is a chronic infection, 24 hours a day, 7 days a week in untreated individuals. And if you do the measures in the gingival tissue, it literally is like having an open wound the size of the palm of your hand in your mouth, untreated. That can very easily seed bacteria, this massive bacteria from the oral cavity, into the bloodstream. We know that happens. That's not a good thing for any of these diseases. Also, these bacteria that get into the bloodstream will cause an upregulation of systemic inflammatory responses. Again, things that can have a common effect on a variety of these clinical parameters. And I'll show you some of our data on that today. So the non-human primate model, now taking these fundamental principles of periodontitis and how we look at it, how do we use the non-human primate model to explore this? Well, it is a ligature-induced model. That is, we actually tie a silk suture around the neck of the tooth of the animal, put it down below the gingiva, which creates an inflammatory and infectious nidus at that site. The more of these we create in the mouth, the more severe the disease that the animal has. The primates we know are clinically, microbiologically, and immunologically similar to human disease. I'll show you some of those parameters as we go along in the studies. And as importantly, in a human population, when they come in to the research enterprise or the physician, the dentist office, you never really understand where they are in the process of the disease. Is it early in the biologic process? Is it late in the clinical process and maybe represents a healing approach? You never have that information. In the primates, we know when it starts because we started. So we actually can manipulate the disease. We can start it in a single site or in many sites within the animal, and we can monitor then very actively both the local and the systemic responses of the host to that initial challenge of this ligature model. A picture here, this is a cynomolgus monkey over here to give you an idea of what they look like clinically. Again, we see some plaque accumulation here in the animals, although normally they're on a hard chow, which actually does provide some amount of cleaning to the teeth. You might be able to see, the lights might knock that out a little bit, some gingival inflammation here. And highlighted in this red box, I hope that you can see these dark areas down here where we've actually tied the ligatures around these teeth. The gingival tissues and the bone literally recede away from that challenge. They're trying to escape from that bacterial challenge and the associated inflammatory response to that bacterial challenge. The model in general, although we modify it a little bit depending upon the studies, is we take a group of animals, provide them some oral hygiene so that we get them to a similar level of dental health. We then put them on a soft chow diet, so we take away their natural toothbrushing from their hard chow by soaking the chow, making it very sticky. So that actually creates about a 4-week phase of experimental gingivitis. So we have an inflammation of a gingiva, accumulation of bacteria. At that point, we actually tie the ligatures and then monitor the disease generally over about a 3 to 4 month period that we can see the associated clinical features of disease similar, if not identical, to that is seen in human beings. The outcome of that process is that in these, this is an apical radiograph of a non-human primate mandible, and I think you can probably see the darkened areas in each of these spots where we had ligated. That is alveolar bone resorption. So the bone around the teeth has been challenged by this bacterial trigger, creating an inflammatory response and causing bone resorption. We can actually quantify that as part of our measuring system. You can't read all of this, nor would any of you probably want to read all of this, but what it amounts to is to give you a flavor for the variety of bacteria that inhabit the oral cavity. Within the human population, it's now estimated that about 700 species of bacteria inhabit the human oral cavity. In each of us, it's probably about 75 to 100 different species live in your oral cavity. They represent a whole variety of species. They represent a whole variety of bacterial phyla within that. The thing that I wanted to present here is that looking at the distribution of those organisms in health in humans versus periodontitis in humans gives you an idea of the kind and changes of those organisms. This is cynomolgus monkeys healthy in periodontitis, rhesus monkeys with gingivitis, and baboons that I'll talk about today as well with gingivitis and periodontitis. And fundamentally, you take a look at this and there's a lot of similarities. They're not identical, but for the most part, the microbial ecology of these non-human primates is extremely similar to human bacterial ecology in the oral cavity, and the organisms are generally antigenically related and species related, so primers and antibodies go back and forth across these species. When we tie that ligature and we accumulate this bacteria and we make the change from health to disease with new bacteria showing up, we see a tremendous local response to that, as you would expect. You put stick a splinter in your finger, you get a localized inflammatory response. That's what's happening here. If we look at this local milieu for inflammatory mediators in gingivitis, which is sort of the salmon bar, and periodontitis, which is the yellow bar, these values are compared to baseline, so it's how they change versus where they started. We see an increase in a number of the usual suspects that we associate with inflammation, pro-inflammatory cytokines and tissue destruction. Many of them are significantly elevated in periodontitis. So we create this localized infection. We know where it's happening. We can collect that samples from that environment and actually demonstrate that the host is actively and aggressively responding to that local challenge. However, with respect to where I'm focusing today, it's the link between this oral challenge and the systemic challenge that really is the more interesting for the topics today. And with any type of a local challenge, you actually can see manifestations of systemic inflammation. It is the system that tries to protect our overall body from these noxious challenges in our environment. And this encompasses a group of acute phase cytokines that can circulate and elevate in the blood to trigger this response. It also has a unique group of about 25 or so plasma proteins that specifically respond during acute challenges. So they're called acute phase proteins or acute phase reactants. The one on the top of the list here that most of you are aware of, C-reactive protein, is one of these acute phase proteins. However, there are a whole variety of others that engage bacteria, that engage viruses, that try to capture nutrients, all of which are there to fundamentally protect us from an initial challenge by an infectious agent or a noxious material. So what do we see in our monkeys that we ligate and create oral disease in our monkeys? Well, we see changes in the systemic circulation. These are a number of the markers that we looked at in the serum of these animals. During gingivitis, again, the salmon bar, and periodontitis, the yellow bar. And again, once we create this tissue-destructive disease, allowing this infection and inflammation in the oral cavity to more effectively communicate with the systemic circulation, we see a systemic response to that. So local challenge creating a systemic response, and we see a number of these increase significantly over time. Basically, the bacteria that are causing this to happen, that are in the systemic circulation, and this inflammatory response in the systemic circulation are the biological principles that we're suggesting relate oral infections of periodontitis to systemic consequences of that disease. So in summary for this first little section, we do see variations in natural expression in our animal model of gingival inflammation and destructive periodontitis, quite similar to if you would sample a human population. When we tie a ligature around the teeth, we see changes in total and specific bacteria that we would predict are associated with a pathogenic process. We see increases in local inflammation in the gingival tissues, and that this disease can be maintained and extended over a period of time. And the one model I'll show you will emphasize that more. We see multiple local inflammatory mediators, lipid mediators like prostaglandins, cytokines, chemokines, a whole variety of acute phase reactants that occur as the disease progresses. And finally, to segue into the next part of the talk, we see systemic bacterial and inflammatory markers associated with this localized disease. So the snapshots of the models that I'd like to present to you today are really three. The first is looking at periodontitis in pregnancy, again focusing on preterm birth, low birth weight outcomes, and how oral disease, how we might model that using this system. In this case, we're using the baboon model for this, and I'll describe that to you and show you some of our data. And then talk about periodontitis and aging, and we're working actually in two models. Both are rhesus models. One is in caloric restriction as a method to prolong aging, asking how that affects inflammation and oral health, as well as some recent data that we've just gotten that I want to give you a little bit of a flavor for the kind of things that we're doing, which is looking at ontogeny of innate immunity, but using the oral cavity as a model to study host bacterial interactions. This first slide to give you a little bit of background on the sequela of preterm low birth weight infants. It unfortunately continues to increase across the United States. Over the last 20 years, it has increased by about 25% in Kentucky alone, even in the presence of the improved health care that we have for our population. Preterm birth, low birth weights have acute morbidity and mortality, as well as long-term adverse consequences to these infants. The data that I have here, although it hasn't changed a whole lot, is that if we look at the rate of low birth weight infants in 98, which was about 8% in the population, 65% of all infant deaths are associated with that subset of birth. So a tremendous immediate impact. Long-term neurologic abnormalities, respiratory illnesses associated with lung development, links to adult susceptibility to type 2 diabetes, obesity, and cardiovascular risk. So not only do we have this acute issue that has both social and economic consequences to the population, but long-term subsets of these newborns have challenges to them throughout their life. So anything that we can do to affect this rate, to lower this rate, would be a positive impact. And I'm suggesting to you that improving the oral health of expectant moms may be one way of actually accomplishing that. Over the past about 10 years, there's been a number of different studies that have been done supporting a link between periodontitis and pregnancy outcomes. It's all linked to this chronic infection and chronic inflammation. It appears in some studies the more severe disease in the expectant mom, the greater the risk of preterm low birth weight infants. A number of studies from not only the U.S. but all over the world have suggested this. Although please don't walk away at this point in time feeling that this is a slam dunk issue, because there are studies that do not show this relationship. So we're still trying to understand what are those parameters. Is it the entire population of expectant moms that are inherently at risk, or some subset that we need to identify and focus on? So what we proposed to do was to actually try to model this system, recognizing the challenges within the human population. We said, could we model the relationship between oral disease that we can create and control and preterm low birth weight? And we're using a baboon model, Papio annubis, which is the olive baboon. This is a pregnant female baboon and a baby from it. And we use this model, one, because there's a National Primate Research Center in San Antonio, which houses 4,000 baboons. So it gave us, and they've been doing that for 25 years, so it gave us a very robust population to choose from for our study. And also, we had to manipulate the moms during their pregnancy. And all the veterinarians said, if you're going to use a non-human primate model, the baboon maternal fetal and maternal neonatal linkage is the strongest of those. So you have the greatest or the most limited likelihood of adversely affecting that with things that you need to do in your study. So for those two reasons, we're working with the group in San Antonio. Our study design the experiment has three aims. We take a group of 200 experimental animals that we enter into the study, do a clinical exam, collect bacteria, look for blood endotoxin, which is a marker of systemic bacteria, fluid from around the teeth, as well as blood for sutures at this baseline. We then ligate 3 teeth in the upper and lower quadrant on one side of the mouth. So we create 6 ligated teeth to start the disease process. We have a similar 200 control population that we sample but do not ligate. They then are introduced into a harem into male. Usually it's about 25 to 30 females with a male who smiles quite a bit, I suspect. And then determine pregnancy in that group, which usually ranges anywhere from, I suspect, almost immediately, although I can't tell you that for sure, to about 30 days after the males are put with the females. At about midway through the pregnancy, which is determined by clinical observation, there's an ultrasonogram that is done so that we can actually get an accurate gestational age of the animals. We sample them then about midway through pregnancy, again for their oral clinical presentation, biological specimens, and then we actually ligate 6 teeth on the other side of the mouth. So now throughout their entire 6 months of pregnancy, they have had a chronic periodontal disease, going from an initiation to a much more severe disease when we ligate all of these sites. We then capture the neonatal birth weight and the gestational age of the infants, sample the moms one last time for their clinical presentation and biological specimens, remove the ligatures, and put them back in the colony with their neonates. So that's sort of the experimental design, and I'll show you some of the data that we've gotten from that. This first one looks at the clinical presentation. This is a composite of inflammation and tissue destruction in the periodontium in these animals. It's looking at this presentation in 212 female baboons that were part of this study at that point in time. And the only thing I want you to see here is the tremendous variation. We have some animals that actually start out having rather severe periodontal disease, and other ones are quite healthy. And again, this has no outside influence on this. This is just the normal variation that we see in the population. You'd see something that looks quite like this in a human population as well. The questions we ask then is what happens to them based upon that initial variability. And what occurs is that we can actually group the animals into a group that starts out with fairly low inflammation, a very healthy looking group, a group that we're calling moderate here, which primarily is gingivitis with gingival inflammation, and then a group that is a high level here, which tends to have individuals showing destructive disease naturally occurring in the population. So these are the baseline measures for those 3 groups. After we ligate them midway through pregnancy, we see significant increases in periodontal disease in each of the groups. And then after we ligate a second set of teeth, at the end of the study, we see even a greater increase. So we predicted that we would create an ever-increasing severity of poor oral health in these expectant baboon moms. And we'll now ask the questions about what are the biologic features of this clinical change, and how does that translate into outcomes of preterm and low birth weight. This is taking those individual groups and sort of homogenizing them together to show that we only see that change in the experimental animals. This is baseline, mid-pregnancy and delivery, significant changes in decreases in oral health. If we look at our control population, we don't see any change during that same time frame. So these clinical changes are clearly due to the ligation and the disease that we are causing in these animals. If we then ask how does that local response and local challenge relate to systemic responses, and that's what this slide shows you a little bit of the data that we've gathered on this. In this case, we're looking at a variety of mediators on this axis here, inflammatory cytokines and chemokines, acute phase reactants. The brown bar here is the baseline sampling, the salmon is mid-pregnancy, and then the orange bar is delivery. And again, not getting into discussing each of these in detail and how they might have a role in this process, you can see some mid-pregnancy changes in prostaglandins in the animals, significant increases in IL-6 and IL-8 as markers of an inflammatory response to this local challenge in these moms. They don't all go up, though. In fact, one marker here that helps protect us against gram-negative bacteria actually decreases significantly in these moms with the disease process. So the host is clearly systemically reacting to this local challenge in these moms, which is what we had wanted to occur from the very beginning, and the hypothesis for the experiment was we could change the systemic responses by causing this local disease. We also see substantial changes in the specific immune responses. The last slide was sort of the non-specific innate responses to this infection. We also see antibodies made, so the adaptive part of the immune response, and some of these antibodies do actually change. The ones here in the yellow bars do change during the infection. We're still in the midst of analyzing this study, so I don't have anything more than just sort of this vignette to show you that we get both innate immune changes and adaptive immune changes that occur to this local disease. And then finally, in this data set, I wanted to show you that we actually have measured the presence of endotoxin in the blood of these animals, so that we have communicated this local oral infection, many of which are gram-negative anaerobic bacteria. We have communicated that challenge into the systemic circulation by delivering or translocating this challenge from the oral cavity. On this side, again, baseline in the brown, salmon here mid-term or mid-pregnancy, and then the yellow delivery. We see increases in the level of endotoxin, although they haven't reached significance at this point in time. However, if we look at the frequency of animals actually showing this, we have already seen a significant increase in the frequencies of animals that are systemically challenged with endotoxin during their pregnancy. That gets us to sort of the last question in this model, and that is, where are we in having an understanding of the effect of that local challenge on the birthing outcomes? And we still have about a quarter of the animals to finish or to finally give birth in this study, so I don't have the final numbers on birth weight and gestational age, but I have some preliminary data that looked really exciting, and I wanted to pass it along. The first is that in the experimental group, we have almost twice as many stillbirth or fetal demise occurred in the experimental group as the control group. And that is already tending to be at a level of significance, although it hasn't reached it yet. If we then take our control population and determine the mean gestational age and the mean birth weight of the control population, what we find is only about 5% of our experimental group animals have a gestational age that is sort of less than a 5% of that control variation. However, we have 16 to 17% of our experimental animals that have low birth weight babies or low birth weight related to the gestational age of that infant. So at least in this preliminary assessment, it does appear that our experimental animals are altered in their population birth dynamics, and we do seem to be increasing the frequency of at least birth weight by using this model system. We then ask the question, which is logical, and say, well, do the ones that have these adverse pregnancy outcomes show us the worst clinical disease? That's what we would have predicted. Well, at baseline, there's really no difference. So we don't have any prediction of who's going to go this way based upon their clinical presentation, and we're sort of at that same stage with the human population as well. When we look at the differences in clinical presentation of the adverse pregnancy outcome versus the normal birth population, at mid-pregnancy, we do see a difference, and it won't take much longer if it holds this for that to be statistically significant. Interestingly, by creating more disease throughout the later stage of pregnancy, this is during the first half, this is the second half, they tend to normalize out. So it appears that if this is going to have an effect, where it's having an effect is during that first half of the pregnancy in this model system. If we go even one step further and we say, how does this clinical presentation relate to the most extreme of these outcomes, and that is stillbirths or fetal demise. This is the brown is the fetal demise and stillbirths in the experimental population. The salmon is the rest of the experimental population. And this is stillbirths and fetal demise in the control population, because we did have some, and then the rest of the control population. And again, not too much at baseline, dramatic difference here, and almost a stepwise process of worse clinical presentation worse pregnancy outcome. So it looks as if, at least in these initial analyses, that particularly with this most severe of birthing outcomes, we may actually have a model that will allow us to examine the biology of that. So in summary, we have female baboons. They demonstrate variations in natural oral health, some not so bad, some a lot. They also vary in serum inflammatory and immune parameters. When we tie ligatures on them, it increases destructive disease. We create periodontitis in the moms. It changes their serum antibody, and it also changes systemic inflammatory mediators, all part of the biology of what we view as part of this system. The outcome of that periodontitis, at least at this point, is it looks like we increase stillbirth and fetal demise outcomes. It looks like we do increase the frequency of low birth weights and potentially weight per gestational age. We do see an increase in oral disease in those moms that present with adverse pregnancy outcomes. So where we are now is we have to complete the study with 200 baboons in each group. We have about 50 total to go yet. So within about the next 6 months, that should be completed, and we'll be able to analyze the final parts of that data. The second snapshot I want to talk about is the idea that oral health is related to aging. And while we don't necessarily have to consider aging as a disease, since I'm sort of part of that process as well, we have to ask the question, does poor oral health contribute to negative outcomes in the aging process? Does it go together with other aspects at the individual level to make aging a lower quality of aging in individuals? Caloric restriction has been a model that's been used for decades in rodents. It is the only non-genetic model that increases age or extends age in rodents. People are now looking at it in primates and in human studies as well. It reduces body fat, changes plasma insulin level, affects body temperature, actually lowers that, alters a variety of biological measures, all of which are consistent with good things, things that are associated with healthy aging. It's widely accepted, as I said, as the only non-genetic way of extending aging. And we're suggesting that this calorie restriction may also contribute by altering the inflammatory response, and proposed that we could study it in the non-human primate model, using the oral cavity as a model of host bacterial interactions. So the study objective was to determine the effects of caloric restriction on the prevalence and severity of periodontal disease in male and female non-human primates using rhesus monkeys. If we look at calorie-restricted animals, these are juveniles, adults, and aged animals. Obviously, you can see a tremendous progression in poor oral health here. Again, not dissimilar from what we see to the human population. And we see a similar type of progression if you just look at these individual pictures in the control animals. However, when we drilled down into this group of animals in a more detailed way, we found some very interesting findings. First of all, caloric restriction is a 30% reduction in ad libitum food intake. It reduces calories by 30%. We have 81 rhesus monkeys. 35 of them are calorie restricted and 46 controls, both males and females. They range in age from 13 to 40 years for a monkey, which is about 40 to 120 years in a human population. So we do have groups that span sort of an adult to a young old to a rather old population. And here's what we found. First of all, looking at measures of periodontal disease. This is measures of inflammation. These are measures of things that challenge and create the inflammation. These are measures of destructive disease. What we saw is that the male animals, irrespective of what diet they were on, because they were all grouped together, had significantly more disease, periodontal disease, than the female animals. When we broke them down into diet, what we saw is that in the controlled diet, the C diet down here, the males had significantly greater destructive disease than the females. When we put the males on a calorie-restricted diet, we actually made their oral health look more like the females. So we actually did have an improvement in their oral health due to the calorie-restricted diet. If we ask how this related to the aging in the animals over time, again, it's fairly clear here. These are, again, measures of periodontal disease, and I think you can see in virtually all of these measures, we see a significant increase with aging. Again, we would have predicted that from the human population, but this model demonstrated that as well for us. We then have to go back and say, well, what's the biology underpinning this? Are there biological reflections of this change in disease? And all I want to do is just sort of highlight a couple of these asterisks here. These are just systemic measures of innate immune responses, like we did in the baboons, and antibody or adaptive immune measures. And what we saw fundamentally were the males had more aggressive innate inflammatory immune responses or inflammatory responses in their serum versus the females, while the females showed us higher levels of antibody than the males. So we would predict that this adaptive response was actually providing some protection to the females, while the males, for some reason, were much more aggressively responding with a destructive inflammatory response to this challenge. If we ask again how that relates to the age of the animal, the young group, the sort of young old and old, this box highlights, I think you can see that these increase as we go with age. These are systemic inflammatory mediators. And in the younger group, you really don't see much of an effect of the diet. As they get older, you start seeing the diet tempering that response. Again, our hypothesis was that calorie-restricted diet would modify the inflammatory response and potentially return it to a more regulated type of non-destructive response. So the summary for this is caloric restriction. It does affect the severity of destructive disease in males, but not females. It has an effect on the magnitude of the antibody responses to certain of the oral organisms. If we look at gender, the males have more periodontal disease than females. Females have greater antibody, and the males are much more aggressive acute phase response. With age, we don't really see an effect of age on inflammation as measured by our clinical parameters. What we're doing now is a local evaluation of that to determine the quality of that inflammation. So we're looking at the characteristics of that within the local environment. And as we would have expected, older animals have more periodontal disease, although they don't necessarily show more of the local inciting factors. They don't necessarily have more plaque or more calculus that would induce that inflammation. They have a different response to that challenge. Where we're going with that is right now completing a longitudinal study where we induce disease in the different age groups and ask how they respond to a controlled challenge. The last one that I want to touch base on, again, this is some of our most recent data and how we're trying to use the non-human primate to understand the biology of host pathogen interactions. And this one is focusing on innate immune responses. And for those of you not aware, this is a basic resistance to disease. Every species possesses this type of a response down into the worm models that we use in molecular biology. The response is very broad spectrum, but quite nonspecific, so it's not picky on what it's responding to. It throws out the whole kitchen sink, more or less. It doesn't have any memory or long-lasting protective immunity, so it shows up, does the job, goes away, waits for the next call-up. There are a limited repertoire of molecules that recognize these foreign materials, and as I said, these responses are phylogenetically quite ancient. Fundamentally, they are all directed towards threat detection. You don't have a response to the organism or the pathogen the first time your body comes in contact with it. So the body has to detect this only as something not self, as a threat to your health, and we have certain receptors that recognize patterns rather than specifics of that challenge. They trigger a variety of immediate responses, including chemokines and cytokines. These trigger a variety of molecules that end up trying to clear or kill the pathogenic challenge, and these also link to adaptive immunity, so they keep the process going, becoming more specific and more effective in protecting you. What we're doing with our model, the non-human primate here, is asking questions about the ontogeny of this. We have very little information on how this system develops over time in an individual as one accumulates a challenge of the bacteria that colonize all of our mucosal surfaces. We have the oral cavity that we can fairly easily sample to ask that question. Some of the data I'll show you today, we actually have human gingival tissues, and we're looking at gene expression in health and disease. Periodontitis gingiva and healthy gingiva from humans, looking at about 330 genes or so related to innate immunity. Non-human primate gingiva, again, looking at health and disease. The specimens we have are healthy gingiva from young animals, less than 3 years of age. And again, when you look at using a primate model, you want to try to identify what can we do with that we can't do in a human. This obviously would not go over very well with parents taking a hunk of their child's gingiva. We have 3 healthy gingiva from adult animals, 3 samples from periodontitis in adults, 3 healthy aged animals, and 3 periodontitis aged animals. So again, as I said, this is preliminary data, but we're looking at aging effects as well as health and disease differences. And what we find, first 3 slides here, to just give you a flavor for how close these 2 species are in this local response in health and disease. The plus represents a change going from health to disease gingiva that is not only significant at a statistical level, but also generally elevated by about 2 or 3-fold. We have a whole variety of chemokines here. This is stuff that they do. They're present in human gingiva, many of them being upregulated in disease. We see many of them also in the rhesus gingiva as well to help support the usefulness of this model. We look at a variety of cytokines that have historically been associated with protection and or the destructive phases of this disease. Again, we can detect them in human gingiva, some of them upregulated in disease, and a number of them in the rhesus monkey gingiva as well. And the last one with this group is a variety of genes that are more specific for the innate immune response, including a bunch of the pattern recognition receptors that we can detect in human gingiva, and we see many of them, and many of them upregulated in diseased gingiva from the rhesus monkey, supporting that looking at this model, we can ask questions about the changes in the development of this system that we could not do in a human population. I have a couple preliminary slides here where we focused on 2 aspects of this innate immune response. The first is on the pattern recognition receptors. This is a list of them down here. In this slide, we ask, are they different with age? So the red bar represents the ratio of a signal in young versus adults, the salmon bar in aged versus adults. So any time that the bar goes above 1, it is increased in young or aged animals. And we actually do see some of these molecules that tend to be increased, generally not in the young animals. We only see this starting to show up in the aged animals. The second set that I wanted to show you are antimicrobial peptides and acute phase proteins. Again, this is a small list of those. We can see, set up the same way, a few of these show up as increased in young versus adults. A few of them show up dramatically elevated in the aged animals, and some that are actually decreased in young animals and in aged animals. So we see a dynamics to this system that we have to sort out over a period of time in a much more robust experiment. We then were able to ask the question, how does these gene expression relate to disease in these animals? The red bar is adult animals, periodontitis as a ratio to health, and the salmon bar, aged animals, periodontitis as a ratio to health. Again, any number above 1 would suggest an increase in that gene expression in periodontitis compared to a healthy gingiva. Most of these we see in the adults. We do not see many of these increases in the aged, suggesting that the adults may show quite a different response to this local challenge, and how that will result in protection or an increasing disease process is something that will need a larger experiment. And then the last is the other set, the antimicrobial peptides and acute phase reactants. Again, any numbers above 1 in the red, it's increased in adults. In the salmon, it's increased in the aged animals. So fundamentally from this very brief overview of what we've done, we do see dramatic changes in a number of these genes. It's not a general response because we do see a reflection in only specific genes, and those genes in the monkey look a lot like the human. So in summary, where we are right now with this is that we can state fairly confidently that oral commensal pathogenic bacteria, the ones that we deal with in our oral cavity, provide a varied stimulus to host tissues. Using microarray technologies in multiple species of animals, because we've done this in rats and mice that I haven't shown you, we can look at homologous gene expression in relationship to this type of an oral infection. And the similarities that we've already found between the human and rhesus gingival tissue gene expression should enable further studies where we can actually ligate the monkeys, creating the disease, following it from the get-go in young versus older animals, and actually identify very critically the ontogeny of innate immunity as it responds to these bacterial biofilms that we acquire throughout our lifespan. So the conclusions from the presentation, the different models that I presented to you, is that periodontitis is a chronic infection and it has systemic ramifications. We see bacterial translocation getting from the oral cavity into the bloodstream. That's not a good thing, because it likely occurs in these patients, again, 24 hours a day, 7 days a week. There's nothing to stop it. The chronic local inflammation that occurs in periodontitis may also contribute to the systemic level of these inflammatory mediators. We believe that we have good data to show that the non-human primates provide a bridge to document the biological mechanisms, not just the clinical association, but the underlying biological mechanisms of how the host interacts with pathogens in aging, using the oral disease as a model system to study this. And finally, that the non-human primate model of oral disease can be used to look at and examine the biological underpinnings of oral systemic disease linkages. I've shown you preterm low birth weight. We've been doing some studies in cardiovascular disease, and these baboons and some of these species of monkeys also develop a type 2 diabetes as well. It could be studied. So, last but not least, acknowledgments. Obviously, you have to be aware that this incorporates a very broad array of individuals at many different institutions in this collaborative effort. A large group from the University of Kentucky in the human and the primate studies, a group of collaborators from the Health Science Center at San Antonio and the Forsyth Institute in the baboon model. Southwest Foundation is where our baboons are housed. The aging monkeys are housed at the National Institute of Aging in Poolesville, Maryland. So I say the crew there because it is a monumental group of wonderful people that enable us to do this, as well as collaborators at University of Maryland. And then our most recent work is done with the Caribbean Primate Research Center and the University of Puerto Rico, which is great in January, I can tell you, where they house a large colony of rhesus monkeys that they have allowed us and enabled us to submit or evaluate. And last but not least, supported by a number of grants as well as Procter & Gamble over the length of these studies. So with that, I'll throw it out for questions, and thank you all for being here.